So let me watch the numbers. Hey, the numbers are going up. So welcome to your Benco webinar. And again, thank you everyone for joining us tonight. We had a little slow start, but we're working through that problem and we should be getting on really quickly. I know the numbers are going up. I am going to go over the CEs real fast. So let me just start right away. So good afternoon and welcome to your Benco webinar. My name is Kay Huff and I will be your Benco host for this afternoon. Before we get started, I want to go over a few of the CE guidelines. Number one, if you are wanting to receive CEs for tonight's course, please make sure you registered in your legal name. What I mean by that is the name that's on your license. Super important if you get audited. Believe me, I've gone through that. You don't want that to happen to you. Also, if you are wanting CEs, please make sure you are signed in on your own computer. So if you're watching it with someone else, the person signed in will get the CE credits. We need everyone to log in on their own device. Very important. If you're watching it on your phone and you've clicked the link, you're in good shape. However, if you're listening on your phone, we cannot see that. We can only see your phone number. So what we'll need you to do is send me your name, your full legal name, your telephone number, and the title of tonight's course to practicecoaching@benco.com. Again, that's practicecoaching@benco.com. Don't worry, we'll go over that again at the end of the webinar. So if you didn't write that down, don't panic. We'll take care of you. Also, you will be receiving a survey when you receive your CEs. Please fill that survey out. We definitely want to know what you want to see more of. It's really important for us at Benco. We want to make sure we take really good care of our customers. So let us know what you want more of. At the bottom of the panelists, or at the bottom of your computer, there's going to be a Q&A button. Please make sure you put all of your questions in the Q&A. Do not use the chat. So use the Q&A button. And I will tell you, Roy, Dr. Shelburne is really good about making sure that we answer all those questions. I mean, honestly, I want to hear everything Roy has to say. So this is what will happen. If we don't get to all your questions live, don't panic. Roy will make sure he answers all those questions, and everybody on tonight will get a copy of all the Q&A questions, every single one of them. So Roy will definitely make sure he takes care of you. I think I've gone through everything. So this is my favorite part, my absolutely favorite part. I get to introduce one of the managing directors at Benco Dental, who I get the honor of calling boss, who I absolutely adore, Chuck Cohen.
And Kay, it's a mutual admiration society. Good to see you too. Thank you very much for having me, and welcome, Dr. Shelburne. So a couple things on my list to announce tonight. The first one is thank you for everyone for being here. We are blessed and lucky to have Care Credit as our sponsor tonight. Care Credit, as you all know, is a force in dentistry. They're one of the most unsung heroes of our entire profession because they make sure that our patients can pay the bills, that we can continue to practice dentistry, and that they basically make the whole payment system work. So thank you to Care Credit for sponsoring this evening. The interesting thing about Care Credit is the reason they're sponsoring is they want to make sure that every dental practice in America is as up to date, up to speed, and knowledgeable on insurance issues as they can be. So there's no duplicitousness here. They want to make sure that you have the information you need to bill your patients properly for the care you're delivering. So thanks to Care Credit. We're going to talk about them in a few minutes. I also wanted to it's my honor, and I wanted to take the opportunity to introduce our speaker, our featured speaker this evening. So in addition to Kay as our ambassador and our host, or hostess, I should say, we are blessed and lucky to have Dr. Roy Shelburne as our speaker tonight. Dr. Shelburne has a couple of interesting things about him. The first one is I think once a dentist, always a dentist. He's a graduate of dental school. He's an expert on insurance. He's had some run-ins with insurance in the past, and that's what's made him an expert. So he's done it right and done it wrong. And he's here tonight to give a little talk on something that's very important and top of mind for everyone on this call. And that is getting up to speed on the new ADA codes, making sure that you are ready to use them and then you use them properly. I can think of no better expert in the United States than Dr. Roy Shelburne. He's now living, I think, in Florida. Is that correct, Dr. Roy?
No, in Virginia still.
Virginia still. You were in Florida. All right. So anyway, he's still in Virginia. He'll tell you a story, but mostly he's going to get everyone up to speed on how to use these codes correctly. So with that, I turn things over to Dr. Roy and Kay. Thank you for everyone for being here and have a great program.
Thank you, Chuck. We really appreciate that. And we appreciate you
Thank
and
you.
Benco. So,
Absolutely.
Roy?
Thank you, Bernie, for the invitation. I appreciate your inviting me. Appreciate giving me the opportunity to share the information. And it's going to be a great night. We're going to have a good time. But before we do that, let's talk a little bit about CareCredit, Kay. What do you think?
I love CareCredit. Like, I will tell you, Roy, that if I go into a practice and they're doing in-office financing, I the first thing I say is why? Like, why? Like, why do you want to be a bank? Actually, I'm speaking at Yankee tomorrow, and I talk about that. You don't want to be a bank, right? You want to be able to do
Absolutely
dentistry.
not.
As a practicing dentist, what happens when you become a bank?
You have two hats, and one of them you know absolutely nothing about. And by the way, if you do carry balances in your practice, all the states consider you a lending institution, and you have to have all the paperwork in place, signed, and up to date as if you were a bank loaning money on a car. If you do not, and the patient complains that you haven't set it up appropriately, you're going to return some money or not going to be able to charge that patient. So just be aware, it's challenging enough on most of our days to be a dentist and to lead a team and to do all that, but to be a banker on top of that, that needs to be taken off everybody's plate.
And you know, Roy, I will say this too. I think the number one thing and the number one reason people cancel their appointment is because lack of financing. So if you take that off your plate and you allow the professionals to do that, I think it turns everything around. I think when patients leave their office and know that it's all paid for, they're going to show up. They're going to have that dentistry done. And CareCredit really does offer some amazing opportunities for people out there. They offer like 12 months, 6 months interest free. They offer all kind of programs. Am I correct?
Yeah, the offices can do multiple different periods. Had a recent cosmetic makeover, and I used CareCredit to be able to do that. And the practice I went to offered the term financing at zero interest. So who in the world would not do that? It made it easy for me to accept the treatment. And the cool thing is, and Chuck was very, very good at describing this or explaining this, CareCredit has been gone to bat so many times for dentistry, have expended a huge amount of money, and have actually put together the program and came to support dentistry to make sure that it was set up appropriately and as easily as possible. They spent a lot of money, time, and energy with attorneys to make sure that we are protected. And, you know, it's one of the things that I love about the CareCredit, what they've done is you can actually pre-qualify patients. One of the things in my practice and in many practices, a lot of people don't suggest perhaps that they consider CareCredit because they think if they do that application and it's denied, they're going to be embarrassed. I'm going to be embarrassed. I don't want to do that. It doesn't feel good to me. But what they've done is they've actually put together a process where you can get individuals not pre-qualified, but it will tell you whether or not they are going to be approved prior to, and it doesn't pull on their credit history. So it's not a ding on your credit history. Why in the world would you not do that? That is exciting to me. The fact that that person at the front desk can ask the question, would financing ever be something you might need or consider when you're having your dental work done? And if they say yes, and you've already pulled that information and know that they're going to get approved, you can, have them do the application and without any embarrassment at all. I love that.
And you know what, Roy, I'll say this too. I know that like Blue Cross and Blue Shield, a lot of them, if you're not in network, they make the patients pay everything up front. Delta's the same way. You know what? I am so happy that our dentists out there are really and truly taking back their practices and saying we're done with it. Like the economy that we're in right now, and the insurance companies that are cutting their fees. Like what is going on here? We're having a 6.5% increase in inflation, not decrease. So I do believe that CareCredit is a great option to say maybe I've had enough of these insurance plans and I'm ready to get off of them, and this is a great way to offer it to your patients. So we definitely want to say thank you tonight. We will be sending out a link later that if you're interested in having maybe a lunch and learn in your practice, you can click on that link and we will have someone, CareCredit will contact you with someone that will come into your office and do a lunch and learn and tell you about the different options. And especially right now with all the insurance changes that are going on, it's a hot topic, Roy. There's a lot of doctors out there that are fed up and they are like taking back their practices and standing up for themselves. And I'm proud of that.
Yeah, absolutely. We need to take control of our future and our finances, no longer allowing the insurance companies to tell you what you can and can't do.
I totally 100% agree. So it talks about what about
the tail wagging the
percentages?
dog. Who wants to have an insurance company?
Yeah, and so there's a question in the Q&A and it talks about, what about the percentages? But let me just tell you this. The insurance companies' normal write-offs that I'm seeing, Roy, is about 30% write-off. I guarantee you what that CareCredit's charging is not 30% write-off. So, yeah, they do charge a percentage, but at the same time, your doctor gets all that money in their banking account and it's a really win-win for them. So again, we're going to send out that link. All we're wanting to say is that think about it. If you're in the area where maybe you're thinking about moving off that, or maybe you just want to stop being that bank, like Roy said, it's definitely something to look at. So we'll send that link out with the Q&A. Please, if you're interested in learning more about CareCredit, please click on that link and get signed up for a lunch and learn for your practice. So with that being said, Roy, why don't we talk about your program for tonight and let's get started. Are you ready?
I am ready. Do you want me to go ahead and share my screen?
Please do. Let's see. I want to make sure everything's working good and then I'll actually come off and let's see if you can come up.
Okay.
Okay, let's go in presenter's view. There we go. You are set to go, Roy. So I will mute myself. I'll let you know if there's any Q&A. So guys, don't forget, if you have any questions, please make sure you put them in the Q&A below. We'll definitely stop and answer them. And Roy, the floor is yours. Thank you so much.
Thank you so much, Kay, for the invitation. Always great working with you. Thank you. Great working with BenCo. And I'm honored to be able to share this information. I'm passionate about helping offices maximize their legitimate reimbursement. I want you to get every single penny you're entitled to, no more, no less. And learning these new codes is going to be important. And again, thank you to CareCredit. They're such a great supporter of dentistry. So happy to be sponsored by them. So let's start by talking a little bit about where the codes come from, how they are maintained, and it's good to know how they come about. And it's been in a bit of a transition. There was an argument many, many years ago about who owned the codes, the American Dental Association or the insurance companies. And they fought back and forth for a number of years. And finally, they took it to court, and the court determined the way that the codes would be established and maintained. They established the Code Maintenance Committee. And in the beginning, they had 6 representatives from the insurance companies and 6 representatives from the dental world, the American Dental Association and some of the other organizations, dental organizations, had representatives that were appointed to this committee. So being 6 and 6, almost every vote on a particular submitted new code would be a 6-6 tie, and the code would not be adopted. It was very infrequent that new codes were approved by the body because they didn't agree. Insurance companies wanted a code for a particular reason, and the American Dental Association or the dentist group did not want that. So you saw a few codes being adopted, and in fact, codes were only updated every 2 years. If you've been in dentistry for a while, you probably remember when that was the case. You could buy a coding book and it lasts for 2 years. Well, what happened in 2012, the court order that was established that divided it evenly dissolved, and it was reassociated. so that now there are many more dentists on the committee than there are insurance carriers. There are 6 representatives from the insurance community, and there are representatives from the American Dental Association. You have 2 of those. You have the AGD. You have representatives from all the specialties. So you have many more dental representatives on this code maintenance committee than ever before. So the codes have been moving. Of course, they don't move as quickly as we need them to, and there's a reason for that. Anyone in the United States, they don't even have to be a dentist, can submit a code request to the Code Maintenance Committee. And if the Code Maintenance Committee receives that request for a new code by October 31st, then it becomes part of the inventory that will be voted on, reviewed and voted on by the Code Maintenance Committee in March. So this past year, the Code Maintenance Committee was virtual because of COVID. All the years prior to, and even this year, they've determined that it will be not virtual, it will be a live event. Although there is a link, if you want to watch the proceedings, you can contact the American Dental Association. They will give you a link and you can attend that meeting as a guest. So anybody who submits requests for code changes, if it's arrived, if it's in hand in the American Dental Association by October the 31st of this year, then it will be voted on in March the year after, and then will become an active code the year after that. So that's the reason why things are so slow to move. As far as the coding additions, it takes a while for it to move through the process. And unfortunately, technology is advancing much faster than the code. The codes are actually advancing. So there are things, procedures that may be adopted and established today that may not have a code to describe them for 2-3 years down the pike. So just be aware there is a lag. That's the reason why codes are actually updated now every single year. They can agree as a committee, the Code Maintenance Committee can agree if the code has been submitted, but it's not in the form that they want it to be, they want to tweak it a little bit, they can form a committee that will work on that code to bring it back to the committee next year. So as I said, it tends to be a very slow and laborious process, moving from a point where somebody submits the need for a code until it's adopted. And most of the specialties, most of the groups will, as a group or an organization, will work together to be able to bring forth one of those codes, make the submission request to the Code Maintenance Committee. And those are generally viewed more strongly because they have a body behind them that is strongly represented at the ADA. Those tend to be adopted at a greater rate than one if someone were not associated with one of the associations. Just a regular person to be able to submit a code, they can, but you need to work very diligently to make sure it's in the form that they need it. And you'll see in this year's coding sets, they're trying to bring everything so it's uniform. So if they use one word in one code set, then they want to have a similar word in all the other code sets. So they're not multiple words, and we'll talk about that when we go through the code changes, the code additions. But in this year's code set, there are 16 brand new codes. There are 14 revised codes. There are 20 editorial revisions. And what's considered an editorial revision if you change a word or two, or clarify something, or may take out some words that are confusing. It's not changing the code per se, but it is kind of cleaning it up and making it so that it's better to understand or more easily adapted and applied to a particular coding situation. They've deleted 6 codes, and we'll see that those are generally because they have been superseded by other codes. And there are a couple, especially orthodontic, there's one whole group there. We'll talk about that when we get that they've dropped it. And they've updated 8 codes. So let's go ahead and get started in the codes. We'll talk about each one of these individually and hope to give you an understanding. One of the things that I do want to encourage you to do is to buy an updated coding book. With deleted codes in your software, it's important that you update those. Do not delete them.
even though the code may be deleted from the code set, do not delete them in your software because that does funky things to all those procedures that you have actually performed for patients prior to. If you delete it, then it has no code to tie to that service that you provided. So do not do that. Put it to sleep, hide it, whatever you want to do that way. But a deleted code, do not take those out of your software because it does terrible things. So first new code, 3911, D3911, that's an intra-orifice barrier not to be used as a final restoration. So this would be a restoration. You've done an endodontic procedure on a tooth. The gutta percha may be exposed, and the purpose of this is to seal that area. So generally, it'll be a bonded restoration, usually a flowable, so that once the endodontic procedure is done, you've removed the gutta percha at the CJ or however far that's going to be. Then you use a material to seal that so there's a barrier so it doesn't leak. This is separate from the restoration that would be placed afterward. And by the way, closing an endodontic opening on a crown or another tooth, a lot of people think that that is a core buildup. It's not a core buildup. That would be billed as a restoration, depending on whether you're using amalgam or if you're using composite. It would be a composite restoration if you seal that area of the tooth after the endodontic procedure is done. And this orifice sealer will be separate and apart from the restoration. So this is a new code that a lot of endodontists have performed this, because typically the endodontist can fail as a result of a leaky restoration into the oral cavity. So this prevents that. It seals it, keeps it from doing that. Something that's been done for a number of years, but there wasn't a code to be able to describe that procedure. Here's another one, a 3921. That is a decoronation or submergence of an erupted tooth. So your intent is to maintain the root structure of that tooth so that the bone around it will help be maintained as a result of the tooth being there. You're not going to take the tooth out for whatever reason. And the description is intentional removal of coronal tooth structure for preserving of the root and surrounding bone. You may recall that there was a code similar to this that described a third molar, especially in the event that the roots were close to a vital structure like blood vessel or nerves. You might take the coronal part out and leave the root in. This is for any other tooth in the mouth. I would use the third molar descriptor code to be able to describe that. But this one would be an instance where you did leave that tooth in place. And in the event that you're going to do an implant, you might choose to do this procedure. And then once the area is healed, you may at a later point when the patient is ready to go ahead and move forward with the implant placement, you might take the remaining root out at that point. So that would be a separate billable issue that you could use. They've changed the splints, intracoronal natural tooth or prosthetic crowns, the 4322. Now this is when you would actually cut a slot or actually use a burr to be able to modify the structure of the tooth. And this actually is this splint is placed inside the tooth structure. So you modify the tooth. When you bill this to the insurance company, it would be important to identify the teeth that are involved. So if there are 4 teeth splinted together, it would be 23, 24, 25, and 26. In the remark section of that claim form, you should identify the teeth that are a part of that splint. So that's the 4322. Splint, intracoronal, natural, or prosthetic crown. So that includes both of those instances. Also, they updated, or a new code is 4323. That's the splint extracoronal, natural teeth, or prosthetic crown. So this is when you would use some material to bond externally, or you could use wire and acrylic, or however you're going to be able to do this, but you do not modify the tooth. So no cutting on the tooth. The existing tooth is splinted, or teeth are splinted together, and you don't modify the tooth at all. They're left intact, no modification of the tooth in this instance. So 5227, 5228, immediate maxillary. The 5227 is maxillary. The 5228 is mandibular, partial denture, flexible base, including any class, rest, or teeth. So prior to this, they had not divided this, the maxillary mandibular flexible base denture. So you had to identify whether it was upper arch or lower arch. And what the insurance companies are doing with the blessing of the American Dental Association is they are actually codifying the arch. So you don't have to identify on the claim form in the remarks section or with an attachment which arch you're actually replacing with a denture. So this would be 5227 for an upper, 5228 for a mandibular partial denture, flexible base, including any clasp, rest, or teeth. So 5725, rebase hybrid prosthesis. There was no code that describes this prior to. This is replacing the base material connected to the framework. So this would be all on four. You might rebase later on. And as I said, they didn't have a code to describe this. So this would be the rebasing of a hybrid prosthesis, the 5725. The 5765, it's soft liner for a complete or partial removable indirect. A discrete procedure provided when the dentist determines placement of the soft liner is clinically indicated. So this is anytime you put a soft liner in a complete or partial denture, this is the code that describes that. And in your claim, you should identify the reason why you're doing the soft liner. For example, you have hyperplastic tissue that you want to help heal, or whatever it's going to be that you're going to use something soft, because that tends not to be permanent. Give a reason why. Understand there are limitation periods on most of the removable prosthesis. And in many cases, if you bill for a soft liner, or if you bill for a regular liner, or if you change anything markedly on that denture, a number of insurance companies will start the clock ticking again. So if the patient has had that denture for 3 years, and you come in and you do a soft liner, you bill that to the insurance pays for that, that may negate or void the replacement of that denture with a new denture for an additional 5 or 7 years. So if the limitation 5, 7, 10 years, the denture patient's worn the denture for 4, technically they could get a new denture in 5. They could start that clock over again as far as the limitation period if you do a soft reline, a regular reline. So be aware of that when you're doing these. And as you probably know, Kay, I have ADHD, so I chase a rabbit from time to time. This is an instance where you might ask the patient, have the discussion, you know, we need to do this reline, soft reline to get your tissues healthy so that when we take the impression for your new denture, it'll fit better. However, if we submit this to the insurance, there's a good chance that this will change the limitation period. So it'll be another 5 years before you can get that new denture. If you sign a document that indicates you do not want this submitted to the insurance, that would be a method of not having to submit that to the insurance, have the patient pay that out of pocket and not evoke that extended limitation period.
They can do that, Roy?
I beg your pardon?
That's amazing. They can actually do, they can pay it out of pocket and then they don't have to report that?
Absolutely. HIPAA trumps the regulation and the policy of the insurance carrier.
Wow,
HIPAA
that
is a federal law.
itself is, that's amazing. There's a couple, can I ask you a couple of questions real fast?
Absolutely. Absolutely.
And we can bring them at the end too, but they said for the new code that you said, the D3921, can this be used when a crown breaks off and we cannot remove the root of the tooth? That's number one question. You want to answer that one first?
It would be intentional. You would leave it because you meant to leave it. It wouldn't be because you couldn't get it out. If your intention was to take the tooth out, you had no plan to leave it, then that would not be an intentional. If for whatever reason, you weren't able to get the tooth out, you were intending to be able to do that, that would not be described appropriately using that code.
Okay, and then Roy, they want to know if they're having a hard time keeping up with all your great information. They want to know if they're going to be, it says, well, we get a copy of this. I can't keep up with all the writing. I didn't know if you were willing to give that, or do you want them to take pictures? What was your thoughts on that?
Absolutely. No, they can have a copy of this. I provided copies to you guys. If you want to give them to me, they're PDF or the PowerPoint, either way, I'm fine with. Not a
Okay.
problem.
So guys, we'll send that
no.
out when we send out the Q&A. Thanks, Roy.
No worries. Don't feel like you have to write furiously. I know it's aggravating to try to do that and see the slides and to keep up. So you'll get a copy if you want it. Just ask for it. So no
I said
problem at all.
Thank you, Roy. Thanks.
Yeah, no worries. So 6198, this is a removal of an interim implant component. Removal implant component, that is an interim abutment provisional implant crown originally placed for a specific clinical purpose and period of time determined by the dentist. So interim, let's talk about this here. They had used provisional in the past. They've used interim and it's confusing. So they're trying to move the provisional so that all of them are interim. An interim is not a temporary. An interim is something that you placed because you are waiting to see if the implant heals or if the periodontal treatment is successful. So rather than putting forth and giving the patient the whole new appliance, you want to give them something just to give them time to heal, to find out, in fact, are they going to be able to wear that appliance? That's considered an interim. Now, when you document for anything you're doing interim, the document should indicate why you are not placing the permanent one, what you're waiting for, what you intend to review to find out if it would be worthwhile to go ahead and put a definitive prosthesis or restoration in place. Your clinical record should indicate that. Your claim to the insurance should indicate that. Again, however, anytime you place an interim, just like the liner on the denture, more than likely that will move that limitation period forward as well. It's going to kick the can down the street. So that anytime they pay for something like an interim, be careful. That will make it so that the permanent, more definitive restoration may not be covered later moving on. And this would be another instance where they might use do not submit form to have the patient sign. And, most patients, if you have that discussion, they understand by not submitting this and paying this out of pocket, it will allow the insurance company to pay for the permanent restoration at a higher rate. They'll get more bang for their buck if they do wait to be able to do that. 7298, that's removable of a temporary anchorage device, screw retain plate. Now these are associated with plates and it requires a flap. Oral surgeons may use this. General dentists more than likely won't very often, but this is the removal of the temporary anchorage device and it's screw retained very specifically, and there's a plate involved and it does require a flap. So you're going to have to use the scalpel, open up the tissue, be able to remove the plate at that point. 7298, that's removal
Roy, wait a
of
minute.
temporary
Do you want me to ask some of these questions as you go, or how did you want me to do it? Because the people have a lot of.
Absolutely.
I'm sorry, I don't want to interrupt you, but I hate to go back. So I guess this one said outside the splint. I don't know what that means. It just said outside of the splint. Is that a yes or a no?
I'm not sure what the question is.
Yeah, that's all they wrote. And then the second one was, whoops, oh, I'm sorry. She said outside the splint are any codes for periodontics?
Any codes? I'm not sure what that would be in reference to. I'm sorry.
It's okay. And then the other one is there a simple document that you can recommend that we have patients agree to not submit a procedure to the insurance? So they have to get them to sign something.
Yeah, our good friend has designed one of those. Linda Harvey, she's a HIPAA expert, and she's allowed me to share that with my my people. So yeah, if they want a copy of that, be happy to provide that to them.
Yeah, so definitely, I've had 3 of those asked. So yeah, so we'll send you a copy of that. And then does the 6198 apply to doing a implant crown in different regions? So you can submit both the crown and the placement of and the removal, on the 6198?
No, that includes all of it.
Okay, I'll just have to keep, there's so many questions, Roy, like you were like, we'll have to go in and just let me know when you have a break and we'll just keep going with the questions. So go ahead and keep going. Thanks.
That's fine. We'll go ahead. How about if we go through them all, and then at the end, I don't have anything to do, so I'll be with you as long as you need to.
That sounds great. All right.
$72.99 removal of a temporary anchorage device requiring flap. Now, this would be for an anchorage device that is not a plate. So those other two were associated with plates. This one is not a plate. If there's an anchorage device that is just, say, an implant for orthodontics, or some orthodontics will actually put a implant to be able to attach to use that implant as leverage to be able to move teeth. That would be an instance where there wouldn't be a plate. So an anchorage device, usually when the plates are used, those are a fracture or there's a cancer resection or something of that nature where it's not just the screw. The anchorage screw is actually a plate as well as anchorage. And this is a removal of temporary anchorage device without flap. So they're with flap, without flap. They've done this because when those claims were being submitted to the insurance, they always had to explain, was there a flap or was there not a flap? So this has helped clarify and codify it more specifically. This one's an interesting one, the pre-visit patient screening. So the COVID has made us very aware of telemedicine, teledentistry, and it's kind of the Wild West out there. So some states, and I'm from Virginia, I'm licensed in Virginia, and Virginia evaluations cannot be conducted virtually. So although you can have a conversation with the patient, you can kind of clear things up prior to, you can't actually do an evaluation. That's something that you can't submit to the insurance company. The interesting thing, when the insurance companies were polled, they indicated they would pay for the evaluation. But there again, you need to be clear in your state. Can a dentist do an evaluation virtually via telemedicine, teledentistry? And there's been a lot of change as a result of COVID, so that some of the states have adopted some emergency legislation and modifications to the Dental Practice Act where you might be able to do this. But where this comes in handy is to have that pre-screening with the patient before they come in. You can actually go over the health history. You might be able to have them use a camera, and if they're complaining of a particular area or tooth, they may be able to send you a picture of that. All that's going to help to set the patient up so that when they get into the dental practice, they don't have to spend that time filling out paperwork. They don't have to answer a bunch of questions. All that is set up by doing a pre-visit patient screening, and there's a code to be able to do that. And most insurance plans will not cover this, but it's a way to track it to see when it's done or how it's done. And there are some state, say, Social Security or no, Medicare and Medicaid may actually adopt this and make this payable because it opens up access to care to their enrollees. So one of those things that it may be added to in those realms, starting out with the regular insurance companies more than likely will not cover that. The D9477, believe it or not, we finally got a sleep apnea appliance code. Prior to that, we had to use a non-specified code and it never got paid. So some insurance companies do consider it. More and more are becoming more attuned to being able to do that. But this actually, we have a new code, a 9477, custom sleep apnea appliance fabrication and placement. So finally, we have one of those. We don't have to use a non-specified code in the CDT. The 9948, that's the adjustment of a custom sleep appliance. So once the sleep appliance is delivered, this is a code that would describe the adjustment of those. And if this code is like most codes that are adjustments, say for a partial denture or a complete denture, Generally, those will not be covered within a 6-month period or a year after they're placed. So be aware, if this is a covered service, more than likely it's going to be considered part of that initial appliance repayment or payment. It won't be covered, but depending on the limitation period, after 6 months or after a year, it may be covered. And we have a 9949, which is the repair of a custom sleep apnea appliance. So they've added all these so that we have a full suite of codes that describe those things that we might do with a sleep apnea appliance. This is a repeat, sorry. These are revised codes. So we finished with the new codes. And Kay, might be a good time if you wanted to, if you have any questions up close and personal, be able to go over. We might address those now.
I see it says the biggest one we've had is that if you're in network with Delta Dental plans, and this is it's like there's just multiple, so I think it kind of blew up. It says we don't have to submit to the insurance company if the patient decides to pay it out of pocket. Like I think the question is that on the insurance form, you have to answer like when it was last replaced. But so I think people, there's a lot of people that have that question.
Sure. So if a patient indicates that they don't want it submitted to the insurance company, HIPAA trumps the contractual agreement with the insurance company. So disclosing any information about that to the insurance company would violate the HIPAA rights of that patient. So I know that blows minds, but in fact, that is doable.
That's really some really good information. So that was a lot of people's questions. So thank you for going over that. They don't have to have them sign anything is what you're saying though, right?
No, they absolutely have to have, they have to have it signed, that documented, they have to keep a copy of that.
Okay, so they have to have it signed that, okay, so you have to have it signed that the patient's asking you not to submit it
Yep,
to insurance companies.
correct.
Okay. And then
Yep.
guys, those of you that have your hands up, I honestly can't see that. So what I need you to do is put all your questions in the Q&A and we'll answer it from there. It says, how much is the reimbursement for the sleep apnea appliance, Roy?
Well, I'll tell you what Medicare does. It generally is $1,100 to $1,250. Insurance companies are going to, dental insurance will reimburse it much less than medical, so I would always submit it to medical first. And they haven't established the pay schedule for the sleep apnea appliance from dental because it's something fairly new. Insurance companies, when they adopt new codes, they have actuarials that go through and determine what kind of impact that's going to have and what the pricing should be. And that's that code hasn't existed. It's been in play for 26 days. So they don't have that information. So as far as the fee schedule for that at this point, there's no data, no information out there. As far as medical side, I've seen a low of the $1,100 from Medicare to $4,500 from a regular insurance carrier. That would be from the medical side, not the dental.
Perfect.
And I would always suggest that you submit the medical first. And in fact, if it's covered by both medical and dental, medical is always primary to dental.
Okay, and so I just want to go back, guys, and tell everyone that's out there exactly. So I'm getting that same question. Yes, Roy's going to give you a copy of what the patients need to sign. He said he would send that to you. That's been going over and over. And then again, they ask me, so they think it's just for Delta that you have to submit that for, but it's for every insurance company. Okay.
It's for every insurance company, just to cover your assets. Some insurance companies, not just Delta, will require you submit everything to them. And in that event, you have to submit everything to them unless the patient indicates they do not want it submitted. And if you have that documentation, that document signed, like I said, you would violate HIPAA if you actually submitted to the insurance against the patient's will.
And then also, do you have to have a study for sleep apnea?
Absolutely. Yeah. Well, any of the insurance companies are going to have require that you have a sleep study from a recognized sleep study group. So yeah, it's the same thing. It's one of those things you can't send the patient home with one of those take-home studies. It has to be from a licensed sleep study group to attach to, and you're going to have to document in many cases where the patient was not able to tolerate a conventional CPAP.
So it's
Okay,
the,
boys,
you know,
that's-
the
Yeah.
last chance scenario. Okay.
So let's
Let's
move
go with the
on. We have more
periodic.
questions, but I mean, you've got so much to cover. So I'm sorry. Let's just keep going. Let me know when you have time. Keep going.
Oh, no worries. We may need to do another one and just answer questions. So periodic oral evaluations, the green is what has actually changed. So with the changes, I've highlighted green and what the additions are. The reds are what have been deleted, and I'll have a line through those so you can look at these and see what they've actually added. The periodic oral evaluation, it mandates that the findings are discussed with the patient. So to make sure that your clinical records are supportive of providing the service, the clinical record should indicate that the findings were discussed with the patient and the patient was given the opportunity to ask questions and to get them answered. So that's a small change to the periodic oral evaluation. The 180, a couple of the other codes last year, they changed so that the oral cancer screen was mandated. For some reason, they missed this one. So the way it was written prior to, it may include, and oral cancer evaluation was considered may include. Now it's must include. It's part of the ones it includes, so it needs to be done, and your clinical record should document the fact that the evaluation for oral cancer was completed in the 180. That's the comprehensive periodontal evaluation. And that can be for a new and established patient. And by the way, this can be used for any evaluation for a periodontal patient. That's a patient who has periodontal disease, bone loss, or those at higher risk. So someone who is pregnant or is a smoker or diabetic, this is a code that can be used to describe those subsequent evaluations, because this code describes people with periodontal disease or at higher risk. And it's generally reimbursed at a higher rate than a 120. Don't ask for it, you don't get it. But if the patient qualifies and you complete all the things listed here, then you can bill the 180. Insurance companies, some of them recognize it, some limit the amount of time. If they reject the 180, sometimes they remap it to a 120, or if they deny the 180, ask for an alternate benefit of the 120. The 2971, the additional procedure to customize a crown to fit under an existing partial denture framework. This procedure is in addition to the separate crown procedure documented with its own code. So the 2971 is a code. Patient comes in, they have an existing partial denture. The tooth, one of the teeth that the clasp goes around, needs to have a crown on it, or a new crown. So this is an additional charge, and most of the time labs do charge an additional fee for customizing that crown, so it's retrofitted to the partial. So they've cleaned up the wording a little bit on this one, but several offices aren't aware that this is the case. This can be billed in addition to the crown, so it's something that can be paid over and above, because there is typically a lab fee to describe that. The 4265, they clarified, it's a biologic materials to aid in soft and osseous tissue regeneration, and they've made this per site. You know, there was confusion before about, well, how much of the mouth, how much do we do? How can it be billed? So they've clarified this. So if you have 3 sites, you would bill it 3 separate times to describe those grafts. So they clarified that to make it so that it was easier to understand. This is not a new code. I'm sorry, that's wrong. It's an updated code. It's a 4276. Combined connective tissue pedicle graft per tooth. They kicked out the double pedicle graft because that does not necessarily have to be a double pedicle graft. It can be a single. So they clarified that they took out the double. So any type of pedicle graft, this code can describe. So it's an advanced gingival recession, often not being corrected with a single procedure, combining tissue grafting procedures as needed to achieve the desired outcome. So that's a 4246. It's now a pedicle graft, does not have to be a double. The 6012, that surgical placement of interim implant body for transitional prosthesis endosteal implant. They deleted the descriptor here. So it comes with, you know, this understanding that was there. It really didn't need to be there. It's pretty clear what the service is without doing that. So they deleted that portion of the 6012. The 6051, interim implant abutment placement. it still includes the placement and removal. They just thought it was inherent in the code itself. They didn't think it was necessary to maintain that. A healing cap is not an interim abutment. So there is a difference between a healing cap. So a healing cap is that dome type of bit and piece that has an opening in the top for the wrench to be able to take it in and out. An interim abutment works like an abutment. It's going to be more like a post that the restoration goes on. So they made this clear by adding that in it. The 6100, that's surgical removal of an implant body and no longer by report. And the descriptor was also removed. This procedure involves surgical removal of an implant, describes the procedure. So they're not asking for any of this. The surgical removal implant body, it might be important to describe why it's necessary, but as far as by report, they took that out. So you don't always have to have a descriptor with it. And these are all temporary anchorage devices. They remove the part that says includes device removal. So it's considered inclusive, but they didn't think it was necessary to be able to put that in this area now. Oh, I'm sorry, lied. They actually added codes to describe the removal of. We talked about those before. I'm sorry, I got this confused with another one. So the ones we talked about before, removing the anchorage device, the plate requiring flap, the plate requiring device requiring flap. So they actually adopted new codes that we talked about previously that describe these procedures. So they actually took that out. They made it two separate codes so that the removal is not included in the 7292, the 7293, and the 7294. These are revised codes still. The 9613, infiltration of sustained release therapeutic drug per quadrant. So they took out the single or multiple sites. So if you do one site in a quadrant, it's the 6113. If you do 5 sites in the quadrant, it's still a 9613. So it's per quadrant. So regardless of the number of sites that you're placing the release therapeutic drug, and this is like Arestin, then it's per quadrant, regardless of the number of sites that you actually place that. And here a trick to understand as far as the limitation on a lot of plans. More than likely, they will not pay for Arestin at the time of the scaling and root planing or the periodontal surgery. They expect the doctor to wait an amount of time to allow the areas to heal, to find out if they have resolved. So if in the event that you are scaling root planing, you bring the patient back in 6 months and all the pockets have not resolved, that would be the time where you would evaluate the placement of Arestin, and the insurance carriers would consider the reimbursement for that service in that quadrant. If you do it at the time of the surgery or the scaling and root planing, they want to see if the area is healed, so it may not even need to have the Arestin placed at a later time. So that's a little thing you might know in submitting that claim. 9997, dental case management, patients with special needs. They included incapacitation and to provide customized or comprehensive oral health care services. So they updated that. They expanded it to include those who may be incapacitated, and they want to make sure that it's customized oral health care services so that it's per patient. You manage that patient, you customize it specifically for them. It's not a cookie jar type of way of dealing with patient. You've actually taken in consideration the patient's special needs, whether that be health, whether that be physical, and you develop a management plan based on those needs of the patient specific. Changes in category. This is an interesting one. Orthodontic limited treatment. So there was, we'll talk about it in a minute. Orthodontic treatment with limited objective. They struck this part, not necessarily involving the entire dentition. It may be directed at only the existing problem or at one aspect of a larger problem, which a decision is made to defer or forego comprehensive treatment. They struck that, and this is what they changed it to.
utilizing any therapeutic modality with a limited objective or scale of treatment. Treatment may occur in any stage of the dental development of dentition. The objective may be limited by not involving the entire dentition, not attempting to address the full scope of the existing or developing orthodontic problem, mitigating an aspect of a great malocclusion as crossbite, overjet, overbite, arch length, anterior adjustment, alignment, one phase of multi-phase treatment, treatment prior to the permanent dentition, etc., a decision to defer or forego comprehensive treatment. So limited orthodontic treatment would be something that you decide to do for the patient that does not lead to a final. Not an ideal situation, you're doing something less than would bring the patient where they would be at a position of having an ideal dentition and bite. So they've kind of expanded this, and in doing that, they have eliminated one whole type of orthodontic treatment. We'll talk about that in just a second. So the D 1354, they struck interim. So it's a carie arresting medicament application tooth. So interim would indicate that you suggest, the suggestion is that you're going to do something else more definitive later on, when in a lot of cases, when you do this to arrest decay in, say, a primary dentition, you're not going to be able to do the restorations whether the patient is not able to cooperate, but what you're doing is arresting the progression of the decay. It may be a final thing until the patient loses that primary tooth. So this was 1354. They took the interim out so that it would clear it up. This could be something that would be definitive. You're going to use this silver diamond fluoride to arrest the decay on the child's teeth prior to them losing it. And the explanation is changed to application of caries arresting medicament per tooth. So just the application. The next is the 2799. They changed interim to provisional. Like I said, they're trying to keep the language consistent, so they don't use interim in one place and provisional in another, but the definition is the same. Crown, further treatment, completion of diagnosis necessary prior to final impression. So this is something that you place because you can't, or you've decided not to go forward with the definitive restoration. You're doing it to have the patient heal in the process. The 5862, there were some complaints about the description of the component parts as male and female, so they struck that. So the 5862, it's each pair of components is one precision attachment. Describe the type of attachment used. So this is for a removable denture, a clip, theca attachment, or whatever that may be. Rather than calling it male and female, they're just calling it pair of components. They've taken the sex out of it. Same thing with the 5867, the replaceable or replaceable part of a semi-precision or precision attachment for attachment. And this would describe those plastic or rubber donuts that need to be replaced from time to time in partial attachments. So this is a replaceable part. That's something that typically wear out and that you would replace them as necessary. Here they changed again from interim to provisional, 6085, provisional implant crown, when placing a period of healing necessary prior to fabrication and placement of the permanent prosthesis. So they also cleaned up the definitive. They're calling it permanent now rather than definitive. And here's another one where they took out the male and female, the 6091, replacement of a replaceable part of semi-precision or precision attachments of implant supported abutment prosthesis per attachment. So they took out the male and female part. And here's another change from interim from provisional to interim. That's the 6253. Ponic, further treatment or completion of diagnosis necessary prior to final impression, not to be used as a temporary ponic for routine prosthetic restoration. And they took out the fixed partial part, so that didn't need to be there. Another change from provisional to interim, the 6793. Retainer crown, further treatment or completion of diagnosis necessary prior to final impression, not to be used as a temporary retainer crown for routine prosthetic restorations. And here another taking out of the male and female, the 6950, precision attachment, a pair of component constitutes, one precision attachment, and that is separate from the prosthesis. And this is an editorial revisions. Here again, the interim adopted, the provisional has been deleted, and it's just talking about a prosthesis. And these are deleted codes because they had added the other codes that we've actually talked about. The 4320 provisional splinting intercoronal, provisional splinting extracoronal, interceptive orthodontics. Interceptive orthodontics, they have deleted altogether. So there's no such thing as interceptive orthodontics anymore. It's limited. And the 8060 interceptive orthodontics, and the limited, it doesn't matter the stage of development. So these were deleted because they've deleted the whole interceptive type of orthodontics. And they deleted the 8690 orthodontic treatment alternate billing to a contracted fee. This didn't make any sense to anybody, so they kicked that out. So the category that they deleted for 2022 was the interceptive orthodontic treatment. There's no more interceptive. And last but not least, these are the new additions that came mid-year. They were adopted, I think, in March of last year as an addendum, and that's because of COVID. And these are the different codes to describe the testing and the doses, either Pfizer, Moderna, AstraZeneca, or the Janssen. So these are codes that can be used to describe the administration of those codes, or of those vaccinations, codes on the brain. So we've rolled through that like crazy, been very fast, as you've noticed. And like I said, the whole presentation will be yours. Kay, are you going to make the recording available as well?
So absolutely, the recording will be available. So Roy, if you want to stop sharing your screen, and first of all, Roy, but if they also want help from you, you also do individual office coaching, correct?
I do that, yeah.
So and I guess we could send out your information if somebody wants that extra information also.
Absolutely.
So yeah, I thought maybe you'd come back on screen then, and you see the Q&A at the bottom. Let's just kind of go through a few of these because you have quite a few. One of them, like, can we file an 0180 and a 4910 together for a recall patient?
No. Well, yeah, I'm sorry. Yes, the 4910 is separate from the evaluation. So the 180 would be the evaluation. It requires that you do full mouth probing and charting. So whereas with the 120, it is as indicated. It's required with the 180, but you can do a 180 and a 4910 at the same appointment, yes.
And they don't have to be a specialist, correct, Roy? That's for a general practitioner?
No, that's anybody. If you do a comprehensive oral evaluation or periodontal evaluation, you don't have to be a specialist. A regular general dentist can do that.
Okay, and let's see, it says, if a patient signs a HIPAA, do we have to change insurance fees if we are in network, or can we change the standard fee to a non-submitted insurance? So I guess what that was like a big flare up.
Yeah.
So I think you might want to go back and revisit that. So is someone, whether they're in network or out of network.
So you cannot change fees based on if they're in network, out of network, insured, uninsured. If you change fees for a group of patients, that would be considered discrimination against that group. So no, your fee is your fee. If you're out of network, then it makes no difference. If you're in network, can you charge your regular fee if the patient agrees to that? Yes, you can.
So hopefully that answers your question. If you have any other questions, please just type them in the Q&A. I think you did really good. So do you have a revised code for the 2022 handouts, and where would they get it if they need that?
The revised codes, if you enroll in the ADA app, they're also listed in the American Dental Association coding book and the companion. And I'm a big fan of Dr. Blair's Coding with Confidence, Administration with Confidence. If you're into medical billing, the the code, the medical coding book that they have crosswalks every single existing CDT code to the ICD-11. So that's a great reference there. And all those are listed. That the ADA actually owns those codes, and they have to, people who use them have to pay royalties. So that's the reason why they just can't be given out, is because they actually are paid for by the companies that produce those documents. So if you give it away, you're actually, that's a violation of the copyright law. So you can't just give those away, as much as I'd love to. But if you enroll in those programs, they actually are able to do that as part of their services.
And then another one is, do a patient, I guess, does a patient have to sign a form per procedure? If they're, I guess, if they're not going to file the right date. If the question on the insurance form said, when was the last placement, and the patient chooses not to give it to them, or is it per procedure that you need to have something signed?
It would be per procedure. You can combine, say, 3 procedures on the single form, but for every encounter, that signature on the form can include all the services at that appointment that they don't submit it. But then the patient comes in again and has something else done, you're going to have another form signed and have the patient specify which things they do not want to be submitted to the insurance.
Okay, and then another doctor's asking you a question. It says, can you ask a patient to write this letter not to submit for any procedure codes?
I would be careful about having a patient sign a letter that you've constructed. You need to make sure that it meets the requirements. So the one that will be shared will meet the criterion. So you're going to meet the regulations. I would be a little careful about doing it on your own, because you may not have it constructed in a way that is appropriate, and you could get bitten in the behind if it doesn't.
Yeah, because I just want to clarify, because the code, what you were talking about is a replacement code. If someone doesn't want to share the replacement date and they want to pay for it on their own, that's totally different. So I think
it's procedure or the replacement date. For example, patient comes in and they got tooth number 9 knocked out. They don't want to walk around without tooth number 9, so they want a flipper made. The discussion would be with the patient is, ultimately we want to place an implant so you don't have this plastic thing in the roof of your mouth, but I understand you don't want to walk around without a tooth. So if we provide this flipper, we're required to submit this to the insurance company. And by the way, if they pay that, you're probably going to pay half of $500. You're going to get $250. But if you'd rather us to hold that, not send it to the insurance, and hold your benefit for the definitive implant, you're probably going to get $1,500, $2,000, whatever the maximum is. Would you rather have the $1,500, or would you rather have the $250?
I mean, that clears it up really good. Of course,
So
I
that would be one of
I would rather hold it. And so there's not really a code for a provisional, from what I hear you say.
There are codes. There are codes for provisionals, yes. But I'd be careful about using them. I'd be careful about submitting them, because you're going to get that provisional paid for. You won't get the bridge paid for when it comes time to take out the provisional and put the bridge, the permanent bridge in.
You're
So
amazing,
you've lost,
Roy.
like I said, but
So that's great information. So is there a specific sleep apnea code for a consult?
that would be an evaluation. Or if another professional sent them to you, that would be a consultation code. That's a 9931. I can't rattle that one off the top of my head, but there is a consultation code. If another professional refers, licensed healthcare professional, you to be able to take a look at that patient for the sleep apnea appliance, that would be a consult. But if they come on their own to ask about that, then that would be a regular evaluation. That might be a 140. Or if you're doing a comprehensive with a new patient, it might be a 150. If you have perio, it would be 180. It would be whatever that evaluation that you're completing. But if you're just looking at the sleep apnea appliance for the patient and you're not doing the entire treatment plan, you're just looking at that aspect, that would be a 140. They're having trouble sleeping, so that's the problem.
Can I just plug into your brain like Roy that you're just, I mean, like,
That would be,
you're just like
that would be
crazy.
scary.
Okay, so the
That would
next
be
one,
scary.
yeah, well, no, I would just love to have your knowledge. So the next one is that says, Dr. Shelburne, is there a code for an extra lab charge to a custom fit a crown to a night guard? Thank you.
Let me look at that one just again.
So it says, is there a code for an extra lab charge to custom fit a crown to a night guard?
No, it's specific to a partial.
So,
So it would not, no.
okay, so I can get rid of that one. Okay. And then it says, let's see, that's can a D0180 be billed in addition to the D0120 or the D0150? So they want to bill like the
No,
perio.
no, it's only one evaluation. So choose the 150, the 120, or the 180, which best describes the services you're providing. New patient, I do a comprehensive. Perio patient, I do a 180. A follow-up patient that doesn't have perio, I do a 120.
Can they alternate those? Or should, once they're a 180, always be a 180?
If you do the periodontal charting, then it would be a 180. That best describes the services you've done. The patient has perio, you've done the charting, or they had higher risk. I would do the 180 each time. Some of the insurance carriers will limit it. They'll roll it back to a 120, but if you don't ask for it, you don't get it, and it's paid better at 180 than it is at 120.
Okay, and it says, not sure if this will be covered, but the full zirconia crown be coded as,
That would be 2740 a porcelain crown.
so, okay, I gotta keep up with you here. Hold on one second. So let's see, can you put a verbiage for the D9613 and Arrestin in the Q&A?
So yeah, it would be patient had scaling and root planing or periodontal surgery X date. Patient has residual pocketing in this area, has not resolved. Arrestin placed to handle the bacteria and to help the tissue further heal and shrink.
And guys, if you're putting your questions in the chat, I can't do those. I need you to put them in the Q&A. I see some people are putting them in the chat. I can't answer those. So let's see. Did you answer that one? Let me get rid of that one. And then let's see, on this one, it says, is a D4265 is usually not covered the same day as the extraction. Is there another way of billing this to get it to be covered by insurance? So it's a D4265.
No.
First of all, what is
Unfortunately,
D4265?
that's the preservation.
So they're saying
So,
it's not
yeah,
normally covered.
If it's not going to be covered, it's not going to be covered. Can you do it at a different appointment? Probably, but is it the best interest of patient to do that? No. A lot of insurance companies do weird things. It's just to limit the reimbursement too. So unfortunately.
I feel like I'm just like probing your brain. It says, how is the 1206 or fluoride application different from the 1354?
The 1354 is the specific carries arresting, like it's diamond fluoride. So it's specific, and although regular fluoride helps to control the decay and to keep it from getting bigger, it doesn't arrest it. It's to prevent it once it started. So regular fluoride application is not going to stop an active lesion. The silver diamond fluoride, you put it on, it turns the tooth black or where it's decayed, but it actually arrests it. It cauterizes, basically chemically cauterizes all the bacteria. So it actually stops the progression of the decay, whereas fluoride helps to prevent it.
Okay, it says, does the CDT code exist specifically for the full zirconia crown, or should they use the porcelain crown code?
Yeah, by definition, zirconia crown is a porcelain crown. So you would use the porcelain crown code.
Okay.
Yeah.
A new patient comprehensive under 3 years of age, do we charge the D0140 or the D0150? So a new
The
patient comprehensive exam for under 3 years old.
150, if it's comprehensive, the 140 it would be limited. So if you're doing a comprehensive,
Oh,
if
it
you're
says,
doing a
I'm
full
sorry, Roy,
evaluation,
it's a DO 145. I just want to make sure I told you that right.
So- no, so if you're able to complete a full evaluation, I'd use the 150. If it's one of those where the patient is too small and they can't cooperate and they're kind of squirming around the chair and you can't get it all done, that would be the 45.
So again, documentation, right, Roy? So if you do the 0150, please make sure you follow all the rules, because he went over a lot of rules for that one, and make sure
Yeah,
those
you'll
rules
need-
are.
All those things that are listed under the 150 is things that you must do. Your documentation should indicate that you were able to complete all those things on the patient. If you couldn't get all that done, then it was not done completely. You didn't do a comprehensive. You didn't get all those things done. You would have done the 45.
So I think documentation, I think I've heard you say that more than ever, Roy. Document what you do, charge what you do, but make sure it's documented correctly. Is the D
Absolutely.
4381 the same as the D 9613?
No. Oh, they're different. Let me pull that up.
So it's a D 4381 and a D 9613.
Let me pull that up. And read the explanation. Hang on just a second.
Sure.
Believe it or not, I don't have all these memorized in my head. It's kinda
Yeah,
scary.
I was kind of getting worried, Roy, like.
There's some of them that I don't. The 4361, was it?
It's a 4381, the same as a
4381.
9613.
Hang on just a second. Localized delivery of antimicrobial agents via controlled release vehicle in a disease clavicular per tooth. And what was the other code?
9613.
Infiltration of us, which I know. One is in the sulcus, the 9613.
So do you want it, so
So-
it's the same as,
so
so
the-
your answer is
the
no.
No, the 9613, that would be, they make a very, very long acting anesthesia. It's going to last for 6 to 12 hours. So this is an infiltration. This doesn't go in the sulcus. It actually is injected. So
Okay,
this would be, yeah,
so totally different codes.
totally different codes, yes.
Okay, are there any codes for laser treatment prior to periodontal SRPs?
No, interestingly enough, they have tried year after year, time after time to get a laser code adopted, and they haven't. The Code Maintenance Committee, the insurance, both from the American Dental Association and the insurance company, have come to an agreement. It doesn't matter how you accomplish the service, it's the service you do. So technically, you could do perio with scalers, you could do it with lasers, you can do it with a butter knife. They don't care. If you do scaling and root planing, it's scaling and root planing. They do not, the code does not identify how the service is provided.
Okay, and then is there a
So
new code?
unfortunately,
Sorry, go ahead.
go ahead.
So the answer to the laser code is no. I wish there was a laser code. I think it's something that that's one that we all need to get on together and write in for, because I definitely think
Well, I can tell you it's been put forth to the Code Maintenance Committee for the last 7 years, and for 7 years it always goes, no, we're not going to adopt it.
I don't get that. And we've seen such great results with lasers too, so I have a hard time understanding that one. So again,
Absolutely.
let's see, is there a new code for irrigation and removal of embedded food or debris?
Nope.
Okay,
That would be one that you might want to suggest that they consider. Actually, that probably would be best described using the palliative.
okay,
If the
And
patient
then-
comes in with a complaint of that area, if it's not part of something else that's going on.
correct. And then again, guys, yes, he is going to share the forms with you. They're still asking about the forms, so I'll say yes to that one. He's already said that. And then someone made a comment that ultimately patients only get $15,000 to $2,000 for benefits per year. So patients need thousands of dollars of treatment. It won't take long to get rid of the insurance anyway.
That's true.
That's a
And
good reason
I'll
why you have
throw
to have
this-
care credit.
Yes, that's right. And let's put a bow on this. I'll be happy to answer the other questions. Most people don't want to stick around. You know why the reason why the annual maximum has not increased from that $1,500 to $2,000 over the course of ever?
No, tell
Of
me.
the individuals in the United States that are covered with dental insurance, what percentage would you think, Kay, actually use their maximum? So of all the people in the US who have dental coverage, what percentage actually hit the maximum?
I actually just read an article on that because I'm speaking at Yankee tomorrow, and I'm just gonna guess 14% don't just 14% use their insurance. Now, I'm probably kind of a little low.
You're high. It's actually 7.
I was trying to remember what I read. I read it on the plane on the way to Boston because I was speaking at Yankee tomorrow, and it was one of the things I was going to put in my, because that blew my mind when I read that. Like, again, 7% of the patients use their small max that they already have, but they pay billions of dollars to the insurance companies.
Yeah.
And that's why, the insurance companies are they're well off, and our poor dentists
Mhm.
kind of get, they kind of get the bottom end of the deal, right? They're getting their fees cut. Unbelievable.
They absolutely do.
So is
All
it,
cool. And like I said, forward the questions, Kay, and I promise I'm going to go ahead. I will answer them all.
yeah, you know what, Roy, we have so many. So this is what we'll do. They're still coming in too. So I know that we want to run on time. Do you want to answer them via email, Roy, or do you want to keep going? Like, it's up to you.
Let's go ahead and, if you would, more than likely there's some repeats. Kay, if you go ahead and put them all together.
Okay.
I'll go ahead and put the answers in there. And if anybody wants the answers to all those questions, let's find out a way from the enrollees that we're actually attending, we'll be able to get them to them.
Oh, believe me, Maria will take care of that. Maria will make sure they get
Perfect.
everyone. Yeah. So she'll send you a copy of the Q&A. So again, if you're on tonight, Roy, I just want to plug into your brain. You're so amazing. I'm so lucky to call you friend.
Thanks.
Thank you for all the time that you share.
Likewise.
And again, I want to just talk a little bit to end it. I want to talk a little bit about, your services, Roy. So why don't you just tell us a little bit about what you do for dental practices?
Sure. Anything soup to nuts when it comes to documentation, billing, and coding. I do anything from practice evaluations before purchase. So I can, those people who are considering purchasing the practice, I can look at the insurance submissions and find out if they're right billing, there's an opportunity to capture some things that they're leaving on the table, or in the event that they're doing something funky that they shouldn't. If you buy the practice, then you're probably going to make less because you're going to do it the right way, I hope. Also help with the documentation, billing, coding, help put together systems so that you maximize your legitimate reimbursement. It's good to review that from time to time, be able to learn about the ins and outs. And, I just scraped the tip of the iceberg with this. There's all kinds of little nuances that you can do to increase the reimbursement. So we want to help with that as well. Don't want to leave anything on the table at all. Don't want any more than you deserve, but absolutely no less than you deserve. So we can set up systems to be able to do that.
So again, we'll make sure we send out all your information, Roy. Please make sure if you could send us a copy of all the services that you provide. I know I call on you all the time. I don't know. I think I just love it when I can pick up and you answer my phone call. So I'm just felt so honored. But if you could send everyone like a copy of all the services, I would love for you to reach out to Roy. Roy, you dedicate so much time to help everybody. I appreciate you, and I appreciate everything that you've done for BenCo.
Thank you.
We'll definitely have to have you on again.
You as well, Kay. You're one of my favorite people. Thank you. It's always a pleasure.
I love you. All right. Well, listen, thank you everybody for attending tonight, and we will see you next time on your BenCo webinar. Have a good evening. Thanks, Roy.
All
Bye-bye.
right.